The nurse-driven protocols really allow the nurse to act immediately. There's no paging the physician or advanced care provider and waiting for them to get back to you. It's so tough when you're giving these medications and that patient is in front of you and reacting. It's scary and you want to be able to do something for them immediately. So by having a nurse-driven protocol, or at my facility, we call them clinical practice guidelines. And again, it allows for that immediate action and that swift intervention for the patient.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. Today, we're talking with Maura Price, Oncology Clinical Nurse Specialist at the Lehigh Valley Topper Cancer Institute in Bethlehem, Pennsylvania, about what oncology nurses should know about desensitization strategies. Maura presented on the topic during the 2023 ONS Bridge Annual Virtual Conference. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thank you so much for joining us today, Maura.
Thanks for having me, Jaime.
So to start things off, I know we often use the terms like hypersensitivity reaction, infusion reaction, allergic reaction. We kind of interchange those a lot when we talk about reactions to treatments. But what we know is that when a patient reacts to their infusion, that there are some distinct differences in these types of reactions. So to start things off today, can you help define the types of reactions that patients can have to their chemotherapy or infusion treatment?
Absolutely. So depending on which classification system that you're using to define and grade reactions, the classifications can differ slightly. So to give you an example of how this has evolved over time, two immunologists back in the 1960s, Gell and Coombs, really created a broad classification for hypersensitivity reactions and mainly categorized them as either type 1 through type 4 reactions. So a type 1 is an IgE-mediated hypersensitivity reaction, which is more of a rapid immune response, kind of like what we see when we're giving an infusion and have a patient has an infusion reaction. Gell and Coombs type 2 through 4 are a more delayed response, but I do think it's a broad classification, but gives you some insight in understanding the pathophysiology behind each of these reaction types. But then we kind of move into more specific classifications, such as CTCAE, which is the common terminology criteria for adverse events. This actually defines reaction types and grades. So an example is they have infusion-related reaction definition and grading. They have cytokine release syndrome reaction and grading, and of course for anaphylaxis as well. There's another type of classification, which was named by Dr. Brown. So it's called the Brown classification. And this is where the reaction types are not defined, but rather categorized as either mild, moderate, or severe. So I can tell you from my practice, I heavily use the CTCAE, so I can really speak to that better than I can the Gell and Coombs, and then also the Brown classification.
So it sounds like there are a few different ways to classify them. And so what would be important for nurses to understand is, what is the standard at your site of care? What is everyone agreed upon to use to help describe and classify, grade, document what type of reaction a patient might have experienced, and just having clarity on what is the standard.
Exactly. Agreed. I think it's important to have that standard too, because then it's objective grading. It's not me saying, oh, this is what I feel the reaction is, and the other nurse working in the pod with me saying, oh, well, I think it's this. It's very defined and very objective so that we're all grading it the same way.
So you did mention this briefly, but are there specific distinctions or things that can differentiate between a generalized allergic or hypersensitive reaction and like true anaphylaxis?
Yeah, so I would say an allergic reaction is kind of a more general term that's used when someone has an allergy, whether that be to a medication, an environmental allergy. But an allergic reaction can really range in symptoms anywhere from mild to severe. So if a patient tells me, I'm allergic to amoxicillin, or I had an allergic reaction when I take this drug. Definitely ask them to elaborate. What were your symptoms when you had that reaction? Was it GI upset, maybe like nausea, which is would be more a drug intolerance versus hives, lower back pain, maybe even tongue swelling, chest pain? That kind of gives you an indication of how severe that reaction was. So allergic reactions can be anywhere from mild to severe, whereas anaphylaxis is always considered a severe reaction, where it can be life-threatening unless we promptly intervene for the patient.
Thank you for that clarity. So for the rest of our episode today, we'll focus on the IgE-mediated infusion reactions that you referenced. Can you help explain what contributes to the development of this type of IgE-mediated reaction, and what are those symptoms?
Sure. And I will go back to the original Gelling-Coombs explanation. So if you look them up online, and we can certainly link that out in the podcast here, they do have a really great table and picture, again, to kind of understand the pathophysiology of how each of these type 1 through 4 reactions takes place. But with the IgE type reaction and the type 1, where we have that rapid immune response, basically what's happening is the antigen or allergen that the patient is exposed to causes IgE antibodies to bind to the surface of either mast cells, basophils, both of those types of cells. So the next time that the patient is exposed to that same antigen or allergen, there is basically degranulation, or this breakdown of those mast cells and basophils. So when we have those cells breaking down, this causes histamine release, which is primarily responsible for all those allergic symptoms that we're seeing in our patients, right? The itching, the hives, the back pain, sometimes even those severe symptoms, the respiratory and cardiac symptoms, that can be from that rapid histamine release. So that's also why when we have that abundance of that histamine release, typically our interventions during a reaction include drugs such as histamine blockers. We'll often give an H1 blocker such as Benadryl, and then also an H2 blocker. We're trying to block different histamine receptors by giving those medications. We want to stop that degranulation and that breakdown of histamine from happening.
That's great. Thank you for connecting all of those dots for everyone. So you mentioned before that the prompt response is really important when somebody is experiencing a reaction, simply because, as you mentioned, it can range from mild, but can escalate and become very severe very quickly. And so prompt identification, prompt reaction to that is really important to have a good outcome for that patient. So can you talk through how having a nurse-driven protocol can help to facilitate that swift reaction?
Sure. So in my experience, the nurse-driven protocols really allow the nurse to act immediately. There's no paging the physician or advanced care provider and waiting for them to get back to you. It's so tough when you're giving these medications and that patient is in front of you and reacting. It's scary and you want to be able to do something for them immediately. So by having a nurse-driven protocol, or at my facility, we call them clinical practice guidelines. So we have this guideline that we can activate right away. And again, it allows for that immediate action and that swift intervention for the patient. So at my institution, we do treat these types of reactions per symptom. So a few examples: if the patient has rigors, then right in our protocol, we are to give Demerol. If the patient is having itching, flushing, hives, lower back pain, then our protocol is to give Benadryl. If it's a more severe reaction and the patient is having dyspnea or wheezing, again, more kind of respiratory compromise or hypotension, then of course we can move on to albuterol, oxygen, epinephrine. But we really have it spelled out that per symptom, here is how you're going to intervene. So that being said, even though we do have a nurse-driven protocol, there still is always that communication with the provider after the reaction. So the provider is definitely relying on the nurse's assessment and grading of that reaction to really determine best next steps for the patient. Are we going to be re-challenging the patient, or was it too severe of a reaction that we should be considering something alternate for the patient?
I think what you've just described of that nurse-driven sort of evidence-based protocol, leaning in onto the nurse's expertise on assessment and grading, I think that's just a wonderful idea. And I've worked at a variety of institutions that have different levels of that sort of independence and that protocol-driven reaction response. But it is so important to be able to help treat that patient immediately. And, I think, and it can be challenging depending on what types of committee approval and oversight an institution has, if it involves pharmacy and therapeutics, medical staff, things like that. I think it can be complex, but it is very important. You think of a code response. There is a structure of how we respond to that. And we're not waiting for anyone to give specific direction. There's an algorithm. And so I think in this situation, I know we as oncology nurses, when we are experiencing these reactions, they can feel just as scary as a code. And so not having that clear understanding of what can you do, what are the steps you take, that can be a real detriment. So I'd love to hear that your institution has created these practice guidelines, protocol-driven treatments so that nurses can, within their scope, work independently, treat the patient as quickly as possible. But as you said, still engaging with that provider so that typically they're in an exam room talking with another patient, or maybe they're in surgery, depending on what kind of physician practice they have. But we all know that they can't always be there immediately. And so we as nurses, need to be able to act and help that patient as quickly as possible. So I think that you've described just a great kind of balance of both of those things, engaging with that provider, getting clear follow-up instruction, and just being able to talk with them about what you see as nurses, what you recommend based on your expertise of what we should do, and having that collaboration with the physician, I think, is a great way to approach this.
Agreed. And, I think it decreases the patient. And if they have a family member or friend with them, decreases their anxiety. And then also the primary nurse, if we're able to act immediately, stabilize that patient, and then give our full assessment to the provider. As you said, these providers are busy. They're seeing patients in the office. They're in the OR. If we are paging or tiger texting and waiting for that provider to get back, that can take some time. And we know that these reactions can progress easily, especially if it's 2 or more body systems. It can quickly progress into anaphylaxis if we are not intervening immediately. So completely agree with everything that you say. I feel very lucky that my facility has a nurse-driven protocol. I know that is not a standard everywhere, but certainly something to advocate for if your facility does not currently have that.
I am not wired for those high intensity. I'm not meant to be in the ER. I'm not meant to be in the ICU. And I'm not really sure I'm even meant to respond to reactions in infusion. My impulse is I can be your recorder, or I will run to get other people. I'll take care of the family. But I am not wired to be in that high stakes environment. Maybe that's why I ended up being more in navigation and coordination of care in the outpatient setting, where the risks of that were much less. But yeah, it's a very intense moment for the nurses that are there. And as you said, the family, the patient, they're scared. Even if you've given them, they know you're getting an agent that has a high risk of reaction, even if we prepare them, those are scary times. So absolutely, the faster that you can, with confidence, respond to that patient, treat them, talk them through what you're doing, versus them get the sense that you're waiting for the doctor to show up to help guide that response. I think that just instills calmness and control to the situation. It still can progress to the anaphylaxis. It's not a guarantee of that, but it does give everybody the confidence to know what their role is, know how to help respond. And as you said, part of that is somebody reaching out to the physician, whether it's walking to clinic to get them because it's just down the hall, or paging, whatever their mechanism is. It helps to address both of those things simultaneously. So you talked a little bit about not only assessing, but grading the infusion reaction using an agreed upon system just to help identify exactly how severe the reaction was. But it can also help to determine, is this patient appropriate for rechallenge or readministration of that chemotherapy agent? Can you just talk through kind of how that grading influences the recommendation to rechallenge a patient?
Of course. So your assessment and grading is really going to be based on, obviously, what we just talked about, the symptoms that the patient is experiencing during the reaction. So just personally knowing the CTCAE grading so well, this really helps us to identify those next steps for the patient. So if the reaction was mild and more of a grade 1 or 2, then we can consider rechallenging the patient after additional meds. We're always giving and intervening at that point. So the patient may already have taken pre-meds prior to starting the infusion. Then we're giving rescue meds to help them through this reaction. So we could potentially rechallenge at that point and either continue the med at the same rate that we were infusing it at, or, per the prescribing information, maybe slow the rate down. Just an example, of course, with Rituxan reactions, Gazyva reactions, That's right within the prescribing information. So you're going to follow all of that information. It's very drug specific. If it does tell you to slow the rate down by half, then you're going to do that. If it's a mild reaction and you are choosing to restart. But on the flip side, if the reaction was more severe in nature, and let's say a grade 3 or 4 reaction, we were giving epi and, kind of intervening with all of the symptomatic medications for the patient, then at my facility, this is definitely physician's discretion to re-challenge. And I'll be honest, sometimes we have patients that say, that just was so terrifying. I do not want the re-challenge. So again, making sure that we're collaborating together as a team, the patient, the nurse, the physician, or that advanced care provider that was taking care of the patient for the day. So having that conversation, what is everyone's comfort level with this? If the patient is uncomfortable or the provider is uncomfortable, then of course we just monitor the patient, typically for at least an hour after their symptoms have resolved. And then we have that conversation about, of course, the patient's anxious. They always want to know what is going to happen going forward? What is going to happen with my treatment? I want to get treatment. So having those conversations about either desensitization, or maybe they're just going to pursue the next line of treatment. So I always like to use the example of a gyne-onc patient that's receiving either typically Taxol carbo for either their diagnosis of ovarian cancer or endometrial cancer. So that taxane platinum doublet is really the gold standard for these patients. We know that that is standard of care for them to receive that doublet chemotherapy. So if the patient has a reaction to the carboplatin, but is willing to continue receiving the drug, if they pursue that desensitization, they're still getting that gold standard treatment. So alternatively, completely fine for the patient if they would not like to pursue that and they tell you I'm scared, or for whatever reason they don't want to go down that path of desens, totally fine to talk with them about alternative treatment options and then second line therapy. That's why it's just very important to have these conversations up front and educate the patients on the risks versus benefits of all of their treatment options. And then it really allows the patient to make that informed decision that's aligning best with what their goals of care are.
That's a really important example that you provided of, even if in the moment it is frightening for that patient or the nurse, if it was me,
right?
Frightening for the nurse, or if the physician is concerned that if that reaction was kind of hedging on a really severe or possibly anaphylactic reaction, it would be unwise to immediately re-challenge that patient, and that there needs to be that thorough discussion, because as you mentioned, there are some times where that therapy is frontline, it is gold standard, and just not doing it is maybe not the best approach if there's any possible way that it can safely be given. And so those really have to be nuanced conversations in those circumstances, because the alternative, if we know that it is going to be dramatically impactful to potential outcomes and survival, then those conversations, I think, need more time to talk through. And sometimes if you're just coming off of a reaction, it's hard for the patient to kind of reconcile that. And so, if they're not ready that day, then maybe there's a course of action that can be appropriate for that day of treatment. But making sure that the final decision on if we try again and how we do that and how can we do something differently to hopefully avoid a reaction, those are different conversations to have. So I think that's a great point that you brought out there. Are there certain nursing considerations that would be different depending on the grade of the reaction that nurses just would have to keep in mind if they are going to be re-challenging?
Sure. So really the severity of the reaction is going to help us to determine, are we going to continue with this current drug or maybe reconsider other options? Again, I know we kind of just spoke about that. As you said, sometimes it takes some time for the patient and their family to really have this discussion. It can be hard to have that day of the reaction. I mean, of course, if it's more mild, I feel it's easier to have that conversation and say, you got this, we're going to get you through. We gave you all of these meds when you reacted, like now is the best time to re-challenge you. But if it is the more severe type of reaction, certainly depends on, is this curative intent? Is this palliative intent? And then again, what is the whole healthcare team thinking as far as a collaborative decision for what's going to be in the patient's best interest?
There are certainly a handful of drugs that we know are more likely to cause reaction. So we're typically aware of those as oncology nurses. We try to talk our patients through that, coach them, kind of give them the information they need so that they can alert the nursing staff when they are actually receiving the drugs. But are there any assessments or procedures that can be used to sort of prophylactically evaluate a patient's risk, kind of know ahead of time if they are more likely to react to certain drugs?
So as far as assessments that we can do, certainly evaluating and looking at that patient's allergy history, knowing that the patient has a history of several allergies or many allergies that you can see in their allergy history, that is a risk factor that places them at risk for having a reaction to one of these chemotherapy agents. Also, Jamie, you mentioned knowing the reaction potential of the drug. So just two that always come to mind, the paclitaxel or Taxol, we always see reactions with that, more so because of what it's mixed in, the cremophore, but also Rituxan. So just knowing that these agents are highly reactive. So making sure that we have the appropriate pre-meds on board for these patients, whether it's your protocol to have the patient take them at home or whether it's your protocol to give them as pre-meds in the chair while the patient is with you. Another assessment that we can do, again, this is specific to rituximab, looking at the patient's labs. So if they have a high white blood cell count and a high LDH level, it is very likely that the patient is going to have a reaction, right? We need to debulk them a little bit first. And by giving that Rituxan, that is how we do that debulking. That always causes a little bit of angst when you have that cycle 1, day 1 Rituxan and you see, oh my goodness, they have a high white count and their LDH is sky high. I always tell the nurses, it's okay, let's be ready. We need to debulk them and then they're probably going to tolerate the Rituxan just fine for subsequent treatments. But kind of knowing some different laboratory values that we're looking for with some of these specific drugs that are going to place patients at higher risk. So that's what I would say as far as assessments that we can do. As far as procedures to evaluate risk, this definitely would include skin testing that can be done. Now, it's definitely recommended that the skin testing be done in collaboration with an allergist who's experienced with this. So there are risks with the skin testing that we can have false negatives and we can have false positives. Sometimes with the skin testing that we do, I'll use carboplatin as the example. We know that typically with carboplatin, patients are reacting anytime between after cycle 6 and 8. So some facilities will do that skin testing just prior to cycle 6 or prior to cycle 7. And if the skin testing is negative, then the patient will proceed getting carboplatin at the regular administration rate. However, if the skin testing is positive, then the patient might be considered for desensitization. So again, I think you have to look at the whole picture. Maybe I do skin testing on my patient and it shows a negative skin test result, but then I go on to give the carboplatin and the patient has a reaction. So just keeping in mind, we definitely do see false negatives and false positives with skin testing. It's certainly not validated for every chemotherapy agent. We know it definitely has value and is validated mostly for the platinum-containing drugs and the taxanes. It still is considered investigational and definitely not widely performed when giving immunotherapy agents.
Great. Well, thank you for all of that information. That's all very helpful. I think you brought up a great point that is worth emphasizing is that we know there is reaction potential at any point. It could happen in any cycle for what seems like no reason because maybe they've received it several times before. But as you mentioned, in many cases, it's more likely to react up front, with the platinum drugs being sort of the unique opposite of that, where it's typically a later cycle where we see those reactions occurring. And frankly, there are some non-chemotherapy or non-anti-cancer agents like iron infusions and things where you also have that risk for reaction. So I think all of this is very important and very helpful because in many of our infusion centers, of course, we're giving both and all at all the time. So just having that constant vigilance, that constant awareness of, yes, there are patients that are more likely, but even the ones that you would assume are going to, smooth sail because they've gotten through those early cycles, still have that risk there. And so it's just important to always kind of know your patients, know what they're receiving, even if maybe they're not assigned to you, and have that sort of work with your colleagues and your teammates so that everyone knows kind of what chair is that first day Rituxan and what chair is that cycle 9 carboplatin. And then also another thing that I thought of as you talked is knowing, have patients received other lines? Maybe this is their second or third line and maybe they've received a platinum before. And so while it might just be the first cycle this round, if they've already received some, I think that's just a different risk to take into account of how many cumulative cycles of platinums have they received and does this put them at a different risk because this isn't the first time they've seen that drug?
That's a great point. And I think one that often gets forgotten for those GYN patients. A great example that I typically use is that patient, again, with ovarian cancer that had 6 cycles of Taxol carbo. Maybe they then went on to like maintenance PARP inhibitor. And then several months or years later, they unfortunately have recurrence. That, like you said, kind of looking back at their treatment history to say, oh my goodness, this patient already had 6 doses of the Taxol and carbo. So even though it looks like it's fresh Taxol carbo, maybe in the treatment plan, they've already been sensitized to that. So as you said, making sure that you're looking back and you know their treatment history. That's a very good point.
Can you talk a little bit about other types of allergy testing that might be able to help identify, the risk for reaction or mast cell activation that would potentially create that increased risk for reacting?
So measuring tryptase levels and concentrations can definitely be very helpful. So what we see is that tryptase is elevated after an IgE type reaction. So when we have those mast cells that are degranulating and breaking down, that rises the tryptase level. And the levels of tryptase are often correlated with the severity of the reaction. So if it was a more mild reaction, we might see kind of lower, yet still elevated tryptase levels. But if it was a more severe reaction, then we do see higher tryptase levels. So that is certainly recommended by many allergists. So, and definitely different protocols for that as well. Doing kind of serial levels of that, maybe 60 minutes after the reaction and then several hours after the reaction, et cetera, to just see how that tryptase level is trending.
So let's talk a little bit more about actual desensitization strategies. Can you just maybe elaborate on just things that oncology nurses need to keep in mind when reintroducing an agent that they've previously reacted to? And what are some things, some thoughts that oncology nurses should have top of mind?
Yes. So we always want to make sure that we understand that we're doing the slow reintroduction of the drug. So the patient is going to be getting multiple doses of pre-meds. At my facility, they do get dexamethasone. So they're taking 20 milligrams orally the night before, and then 20 milligrams orally the morning of the desensitization. Then, of course, we're giving them intravenous pre-medications in the chair, again, at multiple times throughout. So it's multiple doses of these pre-medications. It's multiple bags of the drug that are gradually increased in dose over time. So that's going to help the patient to have that temporary tolerance. Just remembering that with a desens, this is never a permanent tolerance. It's only temporary. So making sure that we are closely observing the patient, getting their vital signs, as you said earlier, educating them, making sure that they know, hey, you've reacted to this drug previously. We, of course, want to keep you on this drug. That's why we're going this route with desensitization. So if you are feeling anything out of the ordinary, you want to let us know right away. Making sure that we have our emergency equipment and medications available and right at the bedside or chair side. Making sure that there's no contraindications for the desensitization. So several contraindications would be Stevens-Johnson syndrome, severe skin reactions that involve skin desquamation, also something that's called erythema multiforme. So those would be definite contraindications for the patient to receive desensitization. So of course, the provider is assessing that. So that would not come down to the nurse's assessment, but just to make sure that we are being all inclusive of everything that we need to know about this. If the patient did have a very severe reaction, that would be a contraindication for desensitization.
Yeah, those are all great tips to just be mindful of. It does strike me that whether it's different concentrations of drugs in multiple bags, or it is the same concentration, but it's being given over a very sort of slow escalation protocol, my experience has been sometimes those are challenging, if not impossible, to pre-program into your pump and the guardrails and things like that. And so I know that it is very important to have clear communication on how you're programming that pump, how you're putting in the volume that needs to be given, making sure the rate is right, and certainly communicating with your colleagues so that if one of your teammates is actually the one that responds when that next dose escalation is ready to be programmed, there just needs to be clear understanding of kind of what that structure looks like. So whether that is a different form that is created to help step through those different dose escalation rates, if you're able to embed that into your electronic health records somehow, I know that can be complex as well, but I think that's a really important part of the nursing oversight just to make sure that everyone who could potentially help care for that patient and be doing some of dose changing has a clear understanding of what the plan is that day.
Right. And Jaime, you bring up a great point because there really is no standard for the desensitization. So if you were to do a lit search on it, you'll see there are different 12-step protocols, 16-step, 20-step protocols with different rate titrations. So at my facility, in my personal experience, we don't actually titrate the rate. We just give various bags, either over 60 minutes, 2 hours, maybe the last bag is over 2 hours or 4 hours. So that's a great point about whether it's rate titrations or just different bags with different doses over a specified period of time.
So we've talked a little bit about this, but I think it's just something very important for us to summarize once again. Patient education is critical. If they've been through a reaction already and we're looking to desensitize them and re-challenge them, what are some tips in terms of how we can educate patients so that we can just provide them that reassurance that this is a safe procedure to move forward with?
I think explaining the rationale behind the desensitization and why we're doing it is really key. Explaining to them, we want to keep you on this drug that you're currently getting, explaining that whole process. None of us like to go into anything without knowing a plan. So it's even just as simple as giving the patient the plan and explaining the process. You're going to take pre-meds at home the night before, the day of. We're also going to give you more pre-meds in the chair. And explaining why, we want to hinder that immune response. We want to slow that immune response and make sure that they can tolerate this desensitization. Making sure that we're telling them this is going to be very slow administration. So this is not like when you previously received carboplatin over an hour. This is going to be like a 10-hour day for you. And making sure that we are telling them you will be closely monitored. We're certainly giving this in a safe manner. You will be cared for safely. So it certainly does take a lot of encouragement. There can be fear on the patient side with this.
I agree with all of that. And I think this also ties back to what we started talking about early on is this having that protocol and having a response, projecting that confidence to patients so that they know the nurses that are here in front of me not only are going to take great care of me, but they're going to be able to respond confidently and know what to do. And I think if they've already gone through that experience once and they've seen that confidence and they felt that they've been cared for quickly and competently, I think that only helps to reinforce feeling at ease and feeling reassured that they're in great hands. I think that is a huge part, and nurses can provide that. Many times I've also advocated for, and this can be challenging, especially at a large academic center, perhaps where people are really spread out a huge distance. But when I've worked with my physicians, I've always really impressed upon them. It's really important if they can come down and see the patient physically face to face to reassure them as well. I think that goes a long way.
Yes, great point.
Not that patients don't trust their nurses or get that reassurance from us, but I think it just, again, presents that unified front that the physician understands what happened. They know that I had this reaction and they're recommending this as well. And so having that FaceTime with their provider, whether it's an advanced practice provider, whether it's a physician, but just having that sort of reinforced reassurance can go a long way.
Right. The whole team's on board. We're going to get you through.
Absolutely. Well, Maura, thank you so much for all of this great information. I think it's a topic that all nurses who work in the infusion centers understand and go through. But reviewing this, providing some of those clear recommendations that you gave, I think is just a very helpful topic to always discuss and bring back up. So thank you for all that you've brought to this conversation today. As we wrap up our episode, I'd like to go through some quick fire questions just to help summarize some of the main points we've talked about. So to start that off, what are some common misconceptions about desensitization strategies?
I'd say the most common misconception that I hear or get the question about is this is once and done. So definitely not the case. It's not once and done when we do desensitize. Just keeping in mind that is a temporary tolerance to the drug. So every time that the patient is going to receive this drug in the future, that is going to require the desensitization. So definitely get that question from nurses that are unfamiliar with it. And then also patients thinking like, oh, I'll be good after I get this one time over a long day, then I'll be okay. But just reiterating, this is for every single subsequent administration with this medication.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the psychosocial aspects of the care, which we have already discussed in this episode, but it's very scary for patients. And as we said earlier, if they have a friend or a family member with them, it's really a scary time for them. So reassuring all of them, everyone that's there that day, definitely encouraging them. Another thing that I think gets forgotten is just the financial implications of it. So if we have a younger patient or even a middle-aged patient that's still working full time, this is not a short infusion that they were used to prior before they had the reaction. This is a long day. So if they are working full time, making sure that they understand you are going to need to miss a day of work each time that you get this going forward. So I would say some of those psychosocial things are things that are not often discussed, but definitely important to have that conversation with your patient.
I think that's so important. Thank you for bringing that up. What additional training or education do oncology nurses need to further understand desensitization strategies?
I'd say use your resources, certainly pharmacists who are experienced with this. If you do work collaboratively with an allergist or immunologist team, making sure to utilize those resources, ask them any questions or have them explain something that you don't understand. They are the experts on this topic. So, make sure to use your resources. I will also add that Brigham and Women's Hospital are really the pioneers of this desensitization. Even if you just look on their website, they do hundreds of desenses annually. One of their lead physicians, Dr. Castells, is widely published out there in the literature. So really most articles that talk about desens, you will see her name somewhere in there. Those are definitely some things that you can do to help understand these strategies a little bit more. Look through the literature, use your resources, and really just learn more about it.
I love that. It made me consider that even if anecdotally you don't feel like there's a lot of reactions happening at your site, there will always be another one. So you just want to avoid feeling like this one's the first one you've had to do in a long time. You want to have a structure and a process in place. And so again, it goes back to that projecting that confidence to the patient that you know how to handle this and that you're in good hands. And so creating standardized approaches to this so that the next time is even more straightforward and less planning has to be done because you already have a process in place. That is a great way to be prepared. And finally, what are some additional resources, maybe perhaps for patients or maybe other providers who want to learn more or need more education on desensitization or just reactions in general?
As I said, I would definitely direct you to the Brigham and Women's Hospital and just looking at, they even have examples of specific desens protocols that you can use.
Wonderful. Well, again, Maura, thank you so much for your time today and sharing all of this great information with us, our listeners. Do you have any final comments today?
Just keeping in mind that desensitization is a wonderful treatment that we can offer our patients that otherwise wouldn't be able to continue receiving, in some cases, the standard of care drug for their cancer diagnosis. So, I recognize that not every single institution does desensitization, but certainly if it's appropriate for your patient and they want to continue getting that particular drug, definitely helping them find a center that is well equipped and has done many desensitizations in the past.
Wonderful. Well, thank you again so much for your time today.
Yeah, thanks so much, Jamie. Thanks for having me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.